Honestly, I was thinking for a few days about how to approach this. When I thought about talking about high frequency, I realized it should be presented as a story, the high frequency. This can be told as a real story, and if we present it as a tale, it will be much easier to understand. So let's tell it that way. The story of high frequency oscillation ventilation. Welcome. I'll start the story of high frequency oscillation ventilation. With the title, I found that this approach is massive and very contradictory. So much so that I wanted to call it the contradictory approach. It's extremely contradictory and strange. The first thing is, you'll find that this approach is used in terminal cases, meaning it's the last resort you turn to for respiratory support. The time when it might be used as initial treatment, initial respiratory support. There was a big Cochrane review, I think in 2015, that compared conventional ventilation to high frequency ventilation for preterm infants with RDS. They didn't find much of a difference, meaning you could start with either one. That's strange. The second and even stranger thing is that, as you can see, the machine itself is very powerful and odd, both in its sound and the way it operates. Yet, at the same time, it's classified as gentle ventilation. And I'll tell you why it's called gentle ventilation. So, this is something strange and very contradictory. And you also find it is certainly, or even more certainly, indicated for cases of pulmonary hemorrhage, severe hypoplastic lung, and PPHN. As we will tell them, these are the definite indications, and at the same time, it can be used as a gentle mode for respiratory distress syndrome in very typical preterm infants. And you don't necessarily have to keep using high frequency just because you have to switch to conventional ventilation. No, you can use it and even extubate the patient directly from high frequency. I mean, there's absolutely no problem with it. Actually, the most important thing, which I forgot to mention at first, is that this machine may seem very difficult, strange, and complicated, and people might look at it and feel worried or concerned. But in reality, it's a very simple machine to understand. It's actually simpler than conventional ventilation. It might seem like high frequency oscillation is something complicated and difficult with frequency, amplitude, and all these terms and concepts. But in reality, it's much, much easier than conventional ventilation, which is full of modes and details. There are a lot of contradictions. The story of high frequency starts in 1915 with a physiology doctor. His name was Yandell Henderson. He did something very strange at the time. This was the very first idea of high frequency, or its very early beginnings, more than 100 years ago. So the man said, we want to see if gas exchange actually happens within the dead space or not, and what the precise mechanism truly is. He was indeed the very first person to seriously pay attention to this particular topic. So he deeply thought about the concept of the dead space and genuinely wondered if the specific part in the lung, specifically in the trachea, the main bronchi, the smaller bronchi, and the tiny bronchioles, could actually have significant gas exchange happening within its confines. That was the beginning. After that, the topic developed a bit, and the idea came from something rather interesting and well known. Everyone who talks about it says that the idea started with a dog. Someone who was very observant noticed that when a dog exerts a lot of effort, it does something called panting. You know this movement, right? It's a well-known action when the dog pants like this. So someone said that the dog does something strange. It breathes in a very odd and rapid way, and it's not just tachypnea, but something beyond tachypnea. So he decided to think about it logically. And he said, when something is done by God's will, it leads to physiological responses. It causes a specific effect in gas exchange because it helps improve gas exchange. That's where the idea started. After that, the concept was further developed, and the group that actually adopted the idea was a team from Germany and another from Canada. The Canadian team was from the famous Children's Hospital, and the group in Germany collaborated with them. They came up with the high-frequency concept, which is actually a very simple idea. You deliver a very high rate and apply a very deliberate force. Why? That's not what I want to focus on. Why did they go for a deliberate force? Why do you provide assistance? You provide assistance as usual, you provide assistance as usual, and you provide assistance properly, and you provide assistance properly. Why does it make you do this? Logically speaking, what makes you deliver such a deliberate force? A rate of 700 to 800. What does that mean? For a very simple reason, the mechanism of gas exchange in this way is different, meaning there are other methods of changing the gas. It comes with a method of gas exchange. Therefore, you can get some benefits from the other methods of gas exchange. And you will find that I will bring them to you. There are 5 new methods. The normal gas exchange means that you take in air and it goes to the alveolar. So the oxygen from the alveolar goes to the capillary on the other side because it goes to the body, it goes to the gerbils. Because the oxygen or pressure change in the alveolus is higher, it goes to the other side. And that's what it's called, pressure gradient. It moves from top to bottom and vice versa with CO2. It moves from the capillary to the alveolus and it must be higher on that side. This is the normal and expected number for gas exchange. But in the context of mechanical ventilation, you specifically utilize the ventilator that you employ for providing crucial respiratory support and then carefully perform the vital gas exchange process. You find that there are other ways, physical ways, as I told you before. All the ventilation and support in medicine is all physics, based on gas properties. That's why it's very useful for your child from 5th grade up to high school. He studies physics, studies with his friends, and they study together and benefit a lot, understanding many things. Personally, I have understood so many things myself. All right, so you have 5 methods, each with different forms. I can bring them to you if you like. You read in the diagram, in the details, each one has a specific mechanism, a mechanism from physics that creates a certain method for the gases. Exchange. And this practically isn't that important for you to know for the patient. What's important is that we understand it. The idea behind the high frequency machine, let's understand the concept. So when you see a machine, what matters to me is what you notice when you see a machine. High frequency, don't worry, don't get startled by it. And don't think it's a big deal. It's actually a simple topic. The very important slide that we have to bring up every time we talk about this support slide. This is important, and I'll tell it to you again quickly because I want you to know it, not just memorize it. I want you to know it naturally, like you know anything unconsciously. I want you to store it in your subconscious like that. If it is used or invasive, the difference between them is in the endotracheal tube. If it is operationally concentrative, then you want something called a ventilator. And there are 2 types of ventilators, concentrative operational and operational. This is our topic. The difference between them is in the mode, which is a different method, by the way. Operational machines are called devices, devices, devices. It's a bit strange. On the other hand, as we said, they are devices, devices, meaning concentrative operational, meaning you use one of 2 things. It gives flow and it gives pressure, meaning there are machines that produce flow and machines that produce pressure. And the flow or the pressure is converted either to 1 level or 2 levels. So this deals with the major classification. Will you use 1 level or 2 level? 1 level is equal to the bib, 2 level is the bib with the bib. If it's flow, 1 level is the full descent, and this provides either high flow or low flow and multiple levels. It's a full descent. I will talk about it all at once, God willing. The pressure, the critical pressure, will you give 1 specific level or 2 distinct levels with 3 essential machines? The mechanical ventilator or the continuous positive airway pressure device. There are no machines actually called CPAP. CPAP is a therapeutic mechanism. BiPAP is the machines, as we have stated. We will provide one level or two levels, and you have the classification. Going back to high frequency, it is support with a regular tube like this. Supposedly, this whole station is physics. When you blow air into it, it comes out from another side. What's so strange about that? The strange thing is, if you open a port and connect it to the patient, and you run the station, and the air goes out from another side, it will also go to another side, not just down. Pay attention. What's the benefit of it going to another side? It won't go to another side when you close off the second side. You close it with a brush. And this is the T shape. Theoretically, you close it partially and give it a CPAP. And when you close it, you give PEEP, but when you close it, you have to close and open it. The difference with the T tube and high frequency is that you open a port above the port you opened for the patient, meaning above the ET tube port. I'll try to get you the diagram. Of course, high frequency would be better if we could draw it, but there isn't one, so I'll just work with what we have. What? I'll let the air flow normally. I can open it to let it work and then close it. If you want to do something with the upper opening, I put a piston or something like a drum over the opening. Can you imagine it? Can you picture the drum, the ball? It will close the opening and move. It will start to go up and down, closing and opening, and it goes out. This movement is the frequency. This opening will close again because every time it closes, it pushes air inside to the other side, the side that goes to the chamber. It's simple. So that's it. Secondly, you have a regular tube. You open it from the middle and insert it into the endotrachea. And from the other side, just from the top of the tube, you make an opening and put a piston or a ball or anything. And you do this pressing the air at specific rates. This repetition is the frequency, and it's very strong. It starts from 600 to 900, so you keep hitting. So a significant difference of 10 units means 10 units per second, which subsequently becomes a total of 600 units in 60 seconds. And a difference of 15 units then becomes a grand total of 900 units. What exactly is the difference when measured in hertz? A 15 hertz difference specifically means 15 units in speed or cycles per second. As for amplitude, amplitude is the maximum height of the piston, meaning the total distance it travels is the amplitude, much like in typical sound waves. This is the difference between delta P, the basic pressure, and the higher pressure. For example, this drum will hit a lot, so its frequency goes up a lot and increases. The pressure is the MAP, which is the mean airway pressure, and here we measure the MAP. On the other hand, when we precisely measure the top, we specifically measure the MAP, or mean airway pressure, and this particular measurement is quite equivalent to PEEP in some clinical settings and places, but it is not exactly the same thing. PEEP is usually considerably lower, typically around 5 to 7, but MAP generally starts from 10, ranging from 10 up to 50, and it can occasionally be a little bit less sometimes. This significant difference is the primary reason for employing gentle ventilation strategies. Why is it called gentle ventilation in a highway? Because it's not really gentle ventilation for two reasons. First, you are creating a good map, and this good map is contrary to what people think. It means, contrary to logic, that if you do a lot of lowering, you are actually causing derecruitment or barotrauma. No, you are maintaining the stability of the alveoli and the inside so that it remains stable, not independent, but stable, because if it keeps collapsing, it will keep opening and closing. And this causes shearing injury to the fibers. That's precisely why, when you meticulously use air properly, you effectively maintain the delicate alveoli and diligently protect them from the significant injury that regrettably happens if they persistently keep collapsing. That's the very first crucial thing to understand. The second, and arguably even more profoundly important, is that you substantially and significantly reduce the overall volume, because the normal healthy volume is typically around 5 per minute, which is a critical physiological parameter. If your tidal volume is less than the dead space volume, this means your tidal volume is less than the dead space volume. Your tidal volume is less than the dead space volume. Your tidal volume is less than the dead space volume. Your tidal volume is less than the dead space volume. Your tidal volume is less than the dead space volume. Your tidal volume is less than the dead space volume. Your tidal volume is less than the dead space volume. So when do I use this mechanism? When should I use it? As a primary, I have primary and secondary. The secondary is very easy. Secondary means you use the conventional method, the usual method, which is the conventional one. And the primary is not effective with this. That is, it's not effective with the conventional method. So, logically, you look for something other than the conventional, something unusual. You go for the more advanced options. All right, let me clearly tell you this important thing. What exactly is the significant benefit if the person is currently on? There are many and several reasons for conventional common failure. I'm not going to list all the specific and intricate reasons for you at this particular moment, but it is important to understand that any significant failure, regardless of its origin, inherently carries with it a multitude of consequences and lessons. What are the primary indications? The primary indications are very specific, and they are certain critical cases. The first of these is pulmonary hemorrhage. This is very important. The most important reason here is that you need to maintain a good independent seal, because the alveoli are surrounded by capillaries. As a direct and unfortunate result, blood can potentially leak into the delicate capillaries, so the capillary wall must absolutely remain perfectly sealed and entirely independent in order to effectively try to significantly reduce the internal bleeding. Pulmonary interstitial emphysema is very important, and its name is PIE, pulmonary interstitial emphysema. This is a very distinctive condition that is diagnosed only by X-ray, and there are very characteristic features in the interstitium. This area between the alveoli, and it is very unusual, but the primary treatment for PIE is high-frequency ventilation for the same mechanism we are talking about. Its concept works very well for this because it maintains good air exchange and reduces atelectasis, meaning you keep opening and closing, so you maintain stability, achieving aeration with warmth. The last thing, the second point, is the nature of the progression. The more warmth in these cases. It is very rare in practice. Those who have tried it and seen it in practice know it is difficult and persists with it. Severe pulmonary hypertension remains very difficult, and this is beneficial for it because usually the patient often needs nitric oxide. So the nitric oxide is used. It is well tolerated and very effective with high frequency. Okay, these three are very important primary indications and the condition we mentioned. So now that I know this, what are the other parameters if I want to set them on the machine? The ones I have are very easy, as I told you. The concept of high frequency is significantly much simpler in terms of its management and overall handling compared to conventional traditional methods. We meticulously count various modes, and each individual mode possesses its own distinct form, and we also carefully count the processes of triggering, subsequent cycling, and precise timing, and things like that. This is very simple, very simple. What is the aim of air-spire support? Gas exchange. What is gas exchange? It handles oxygenation and ventilation. Ventilation means carbon dioxide, and there are 4 parameters. These are the ones you adjust, and the 4 parameters are divided. 2 control oxygenation and 2 control ventilation. All right, it's simple. The map controls oxygenation. Oxygenation, that's it. These are the things you set yourself. The better the map you provide, the more you achieve, right? Remember, whenever you provide good map, it means you're increasing the mean airway pressure, which leads to better oxygenation. Why? Because it's one parameter with a dual function. Just improve it, and if you increase it a lot, you'll go back to the situation where it has a dual function as well. And the FiO2 is mainly for oxygenation, while the other 2 parameters are for CO2 removal, which is ventilation. If you increase FiO2, you increase oxygenation, but if you adjust the other 2, you affect CO2 removal. If you increase it, you'll be ventilating a lot, sir. It's like having a certain container. The bigger the container, the more water you can remove. So you'll be able to remove a lot of water. When the amplitude increases, it's easy to understand. So we increase the amplitude and increase the delta. Delta P means the difference between 2 pressures. So when the difference increases, you remove more water. All right, frequency. Frequency is equivalent to the rate, just so you don't get confused. It's equivalent to the rate, and amplitude is equivalent to PIP. And as we said, PEEP is equivalent to MAP with some differences. All right, so naturally, when I increase the frequency, what should I do to the CO2? Just like what? Just like what? Just like in conventional ventilation, when you increase the rate, you wash out CO2, right? That's what should happen. It makes sense logically. But here, no. Why is that in high frequency? You need to understand this. When you increase the frequency, you retain carbon dioxide, and when you decrease it, you wash out carbon dioxide in high frequency ventilation. Because quite simply, when you increase the amplitude, meaning if the frequency is low, there may be more room for amplitude. The width increases and it can carry more, provided you keep it fixed. So if you decrease the frequency and increase the amplitude, you remove a lot of CO2, even though you are decreasing the frequency. But do not do both. Do not fix the amplitude and increase the frequency, thinking you will remove more CO2. You'll end up fixing, decreasing, and increasing, so it gets smaller. This will show up in the image. So when you make it smaller and decrease, and then when you increase it, you retain CO2. On the contrary, this is the opposite of the conventional idea. This is important for us to know when setting the initial settings. Work with these 3 or 4 parameters. These are the ones you'll adjust. We said that VO2 is set according to the target saturation. Check if you've reached the saturation you want, say between 90 and 95, then you're okay. So just leave it like that. And if it's too high, decrease it. And if it's too low, increase it. As an initial idea, just as a starting point. But after that, we can talk more. Now, regarding the map, there are 2 situations where you'll set the settings. Was the patient primary or secondary? Primary means the patient was on conventional ventilation and you're switching them to high frequency, or are you starting them on high frequency from the beginning? I'll quickly tell you about switching from conventional to high frequency. They say it's easy and it's done often. They tell you that you'll see the map on the ventilator. When you set it to conventional, the map will be displayed. Take the map value from the ventilator and add 2 to it. Then set that as the map for high frequency. And they also say, for example, set the map and add 2 to it as well. If you set the initial range to 10, then it will be 20. And if the initial range is 2, it will be 22 or 24. After that, you'll see that the settings are coming up for change and frequency. So it's fixed as a constant number. We absolutely shouldn't change it too often. Indeed, it should truly be the very last parameter you meticulously consider changing. In the comprehensive settings, it's crucial to keep it firmly fixed, along with all the other essential parameters, until you have the absolute final version of the thing and can thoroughly follow up on it. You typically start by making it either preterm or term. If it's a term, you would generally pay a specific amount, perhaps 10. If it's a preterm, you might pay a slightly higher amount, such as 12 or even 13. If it's a preterm, you could potentially pay 14 or 15. But let's not forget, there are other important considerations. Is there a way to re-engage with friends at a higher speed? Yes, you shouldn't use it with friends who have preterm friends. Or any problem with the schools or better options or trauma or anything like that, or transferring interactions with preterm friends, any problem there, and what does it mean to transfer preterm friends and why? Because when you create a good map, you reduce the venous return that comes from the head and the brain. So when you reduce it, you increase the activation, and the activation increases within the activation. The intracranial increases the hemorrhage for you, or causes edema, or worsens the existing problem. So we shouldn't use it for something like this. The second point is, in lung pathology, it should be homogeneous and not heterogeneous, because if it's heterogeneous and you apply a good map, the air will be trapped in the areas that have inflation or are distended. And in the other areas, it will increase the valve mechanism, which is the one-way valve mechanism, and this can cause an air leak. That's why the pathology should be homogeneous, like in RDS or PIE. Even though there is infiltration, it should be homogeneous, not heterogeneous. Avoid heterogeneous. Something like meconium aspiration, for example, but that's a relative contraindication. Okay, so how do we monitor the patient when we set the initial settings? We already discussed the initial settings. If the patient is on conventional ventilation, let's say, or if the patient is initially, meaning from the start, you put them on high frequency, as I told you, the frequency. We mentioned it, 10, 12, 14, 15, that is for term, preterm, and extreme preterm, the amplitude. Let's say from 20 to 25 for the amplitude, and the MAP can be set from 10 to 15 for term infants. As for the mean arterial pressure, or MAP, if it's a full-term infant, you can reliably set it from 14 to 15, and if it's a full-term infant, it's quite close to the expected frequency. But on the contrary, we have previously stated that the frequency for a near-term infant is indeed 15, but for a full-term infant, it is also 15. It could be that for near-term, it's around 15, so I'll set it there. So let's think, how are we going to observe the observation? We have to observe many things. The issue of the extent of observation, the issue of the extent of observation, the issue of the extent of anything on the skin. The issue of the extent of observation, you see the observation, you see the observation, and you see how it appears. It could be little or a lot or even more. The most is in preterm infants. If it has reached the abdomen, then that's a bit more. If it's only in the head or above, or you don't see it in the chest. So in that case, we might increase the amplitude. This is a clinical condition, and of course, you check if the patient's saturation has improved, then that's it. Okay, this is clinical. You check blood gases after you disconnect the high-frequency ventilation. After that, half an hour to an hour at most, and preferably half an hour. Why? Why? We mentioned this in respiratory support during weaning, because depending on the type of support, what is the update? After that, you see the CPAP. Also, if the IV is not straight or not stable, whenever the cause increases, you need to check the update quickly so that too much change doesn't happen. And you shouldn't expect this to take more than half an hour at most. An hour, that's for the blood gas and x-ray right away. So after that, about 15 to 30 minutes. You will give it good inflation. You set the building on the keys to see how many are the key points as numerical key points. If it's more than 9, it's a key building. Less than 9, so you can adjust the building. We do the optimization. We've reached the port and understood the optimization, and we know how to optimize. If you want to optimize with the port, for example, you found a higher key value and a lower key value. Basically, you have two things, MAP and FiO2. You can use FiO2 up to 40 at 40. You're fine. That's a good number, and we like it after that. You can use the map after that, because this map, you need to reduce it, but also don't leave the lung closed. You can keep it closed if you have to. You use a high FiO2 in CO2, reduce CO2 washing. You need to have more than just CO2 and frequency. The frequency should be more than just CO2 and frequency, and usually you don't change it. So you consistently keep reducing the carbon dioxide, CO2 levels, and the frequency of its occurrence. This is because this process effectively reduces your overall CO2 footprint. Therefore, it is essential to reduce the CO2 emissions and their frequency. We must actively work to reduce the CO2 and its frequency. But where exactly should we implement these reductions? Or, alternatively, should we consider increasing by just 1 unit? It is fundamentally incorrect to simultaneously increase and decrease values, especially when moving from 2 to 3 or 4 or even 5. Even if there is a very substantial and significant change, you can certainly increase or decrease, meaning a change from 2 to 5, but not a mere 1 or a drastic 10. So the change will be by 1, and in the end, you'll have to adjust the map by 1, and if you increase or decrease, you decrease by 1. And if you want to decrease a lot, you decrease by 1. You also use the unit, whether increasing or not, you stick to the unit. The FiO2 depends on the saturation, but usually FiO2 is a bit sensitive, especially when you're decreasing it, so decrease it slowly. It's supposed to be decreased by 5, for example, but in cases of PPHN, oxygenation is very important, so you might even use decrease the FiO2 by 2, meaning from 50, for example, to 48 to 46, like that, by 2s. You decrease and increase, meaning the blood gas is essential. We do a blood gas every 4 to 6 hours, maximum 6, because changes happen quickly, so every 4 to 6 hours. After that, when the patient is stable and we've done the initial blood gas and the initial blood gas is good, then we can make the frequency of blood gas every 4 to 6 hours, usually 6, depending on the patient and the severity. The patient might be very sick and very critical, so you try to do it quickly. Like we said at the beginning, you might, you're going to start with high frequency and continue with ventilation on high frequency, then wean and extubate from high frequency, or you might start with high frequency to continue on high frequency and then switch to conventional. If you feel like the settings are good and you want to switch to conventional, it's up to you. So when do we make the switch? If you want to switch, when you're on low settings, the low setting means the amplitude is 20 or less. And the frequency, we said we won't change it. But for example, if we're talking about term babies, we might use a lower frequency, maybe 8 or 9. For preterm, it could be, if we reach 10, that's a very good number for us to switch to conventional, or if the FiO2 is possibly lower. It's important for it to be less than, say, 30, or lower is better. The map is important. It should be well inflated. For the map, if you're, for example, dealing with a term baby, let's say the map, which is roughly the same setting we use from the, and we've mentioned this before in some training programs we do for the, it's basically the map that should be used if it's a term baby, or if it's preterm, let's say. Do you need sedation with high frequency? We used to do it before, meaning in the past we always gave sedation with high frequency. Now, no, it's not necessary anymore. Everyone is moving away from sedation. Why? To improve and increase spontaneous breathing. So be encouraged, and let's try to be more non-invasive, meaning we step back and let them breathe on their own. Unless you really have to intervene, if it's absolutely necessary, then you might. You can give morphine, 5 or 10 at most. I'll show you this at the end. And as you can see in the United study in 2015, high frequency was reported as being used with the unified user, and there was no future outcome to use one of them. Whoever wants to read it, it means he wants to read it. I truly believe that the story of high frequency is actually quite straightforward. It truly does not require an extensive amount of intellectual effort to grasp and comprehend. While it might initially look incredibly complicated or intricate on the surface, In reality, it is exceptionally easy to understand and remarkably straightforward to follow. Management-wise, it's easy for you to handle and manipulate this machine. It's not scary at all, really. So I hope the story was easy to follow and simple and understandable. Thank you. Peace be upon you and God's mercy and blessings.